So ocular surface inflammatory disorders, so the consists of many kind of the ocular surface disease. For example, Stevens-Johnson syndrome, SJS, and ocular cicatricial pemphigoid, OCP, and atopic keratoconjunctivitis, AK, and graft-versus host disease, GVHD. So I think it is very important. Hearing of history is most. I think that the hearing of history is most important to differentiate them. So, for example, SJS have a history of acute onset of SJS, and OCP have no acute onset episode, and AK have usually atopic dermatitis, and GVHD have a history of bone marrow transplantation. So it is not easy to differentiate this disease with only ocular surface findings, especially SJS and OCP. So let's see the several cases. So this is the ocular surface of the 50-year-old male. So what is this? So Virendra, what do you think?
Can I ask you questions?
Yes.
Is there any history of any fever or anything? But looking this, if you don't tell me anything, I think it's OCP.
Okay. So, okay. Yes. So we need the information. So this is the SJS in the subacute stage, and 3 months after onset of SJS. He developed the SJS at 2 days after taking loxaprophen for cold symptom, and was introduced us at 3 months after the onset due to eye problem. So this is a ocular surface, 38-year-old female. So what is this? So Jim, you also need the information, I understand. Okay, so
it's, yeah, I mean, it certainly could be SJS. I personally think it can be very difficult to differentiate the later stages of disease because, you know, biologically, we only have a limited number of ways to respond to insult. There tends to be convergence of various diseases to the same end-stage appearance. This is across, even in corneal disease, this is across disease in general. So I think when you get to this phase, it's hard to know. I would say probably not chemical burn because the lids, you know, the skin looks pretty good. So then I'm thinking about SJS or OCP as the primary cause. And then you tell me it's a 38-year-old female. That makes pemphigoid much less likely. It can occur, but to get to this at 38, pemphigoid, unlikely. Same thing for a 50-year-old.
Okay. So that's right. It is the SJS in the chronic stage, 8 months after onset of SJS. So he developed the SJS at 2 days after taking commercial cold medicine for cold symptom, and was introduced at 8 months after the onset due to eye problem. So this is a ocular surface of 10-year-old male. So continue, so this is also SJS in the chronic phase, in subacute phase, 6 months after onset of SJS. So he developed the SJS without any medication and was introduced at 6 months after the onset due to eye problem. So this is the ocular surface, 33 years old male. So, so this is not SJS. So Giza, what do you think? Giza, Gita, what is this? Gita, what is this? Gita.
I know, we're all subjected to an exam now. Yeah, there's an epithelial defect and is not SJS, you said.
No, no SJS.
So you have to give us some more history.
Okay, so continue. Thank you. Thank you very much. So this is atopic keratoconjunctivitis. He has atopic dermatitis and visited the ophthalmologist due to eye pain. So he had a giant papilla on his palpebral conjunctiva. So this is the ocular surface, 34 years old male. So he is also the atopic keratoconjunctivitis. He has atopic dermatitis and visited the ophthalmologist due to eye pain. Okay, so this is a 40 years old male. So this is acute GVHD. He has received a bone marrow transplantation about two months ago. So this is the ocular surface of 74 years old male. So Gita, what do you think? Not SJS.
Not SJS, OCP.
Yes, that's right. Sorry. So this is a OCP. So his left ocular surface was covered by conjunctiva after cataract surgery 3 years ago, and he was introduced as because his right ocular surface has epithelial defect and also become worse. So this is the ocular surface of 82 years old female. This is also the OCP. Her ocular surface gradually have a gimbal furrow and after cataract surgery 20 years ago. This is an ocular surface of 55 years old female. This is also the OCP. Her left ocular surface was covered by conjunctiva after eyelid surgery 8 years ago, and her right ocular surface was also gradually covered by conjunctiva from 3 years ago. So this is the ocular surface, 69 years old female. This is also OCP. Her right eye becomes ptosis after retinal detachment surgery 35 years ago. And her left ocular surface have the ocular surface epithelial defect and followed by the conjunctiva inversion after cataract surgery 6 months ago. So sometimes in OCP patients, their ocular surface condition tend to become worse after ocular surface surgery. So this is a pre-operation, and her ocular surface become rapidly worse after operation of punctal occlusion. So OCP is considered a subtype of mucosal membrane pemphigoid MMP. Ocular involvement is considered about 60% of MMP. So OCP have no acute onset episode compared with SJS. And usually gradual progress, but ocular surface operation can induce rapid progress. So usually have a severe dry eye, trichiasis, and gimbal furrow, and old person can develop OCP, usually over than 6 years old. So this is an ocular surface, 60 years old male. This is a SJS in the chronic phase. He had a history of acute onset high fever, serious skin eruption, and mucosal erosion, including ocular surface and oral mucosa, without any medication when he was 40 years old. So this is 30 years old female ocular surface. This is also SJS in chronic phase. So she developed SJS after taking cold medicine for cold symptoms 1 year ago when she was 12 years old. This is ocular surface, 40 years old female. This is also the SJS in chronic phase. She had a history of acute onset high fever, serious skin eruption, and mucosal erosion, including ocular surface and oral mucosa, after taking cold medicine when she was 4 years old. So this is a 39 years old male. So this is also SJS in chronic phase. He also had a history of acute onset high fever, severe skin eruption, and mucosal erosion, including ocular surface and oral mucosa, after taking cold medicine when he was 11 years old. So SJS has a history of acute onset high fever, serious skin eruption, and mucosal erosion, including ocular surface and oral mucosa, and usually have a severe dry eye, trichiasis, and gimbal in chronic stage. So any age person can develop SJS. So in summary, ocular surface inflammatory disorders with severe dry eye, trichiasis, and gimbal consist of mainly SJS and OCP. So SJS have a history of acute onset of SJS, and any age can develop. And OCP usually, OCP have no acute onset episode, and usually old person develops. So the hearing of history is most important to differentiate them. Thank you very much. Sorry.
Any questions for her? Good, thank you.
Good morning. The OCP, I want to tell a small episode that I had during the fellowship with Dr. Foster. You know, when I went there, he used to do the lot of biopsies and interpretation and the note taking. The fellow who takes the notes when he's seeing the under microscope, he has to type the. Most fellows did not want to type because it took a lot of time. So I end up being with him all the time, only taking notes and then typing. And indirectly, what it made me very good in interpretation of OCP immunofluorescence. And then when I came back in LVP, there was no one who was doing immunofluorescence, or there was no pathologist. When after 6 months, Dr. Geeta joined. Then 98 October, I went for the academy, and I bought the antibodies from US. And I asked Dr. Geeta, does she know immunofluorescence? She says, no, she never done or don't know. So I had to teach her the immunofluorescence, staining, interpretation. And since then, because the pathologist in LVP has come and gone, so I have been able to continue to do interpretation by myself. So it is very helpful for clinicians to understand these diagnostics tests, even if you don't know, there are ways and means you can learn. Myome, I'll show some acute stage cases also of OCP. So one kind of presentation in OCP can be like this, which different clinical morphologies that you will see. Some of them were said by Myome. So at this stage, it's not really much that in terms of the diagnosis. Other extreme end can be an OCP, which is very early. You just have very subtle fibrosis in the inferior fornix or inferior bulbar conch, which you may not be able to pick up because the patient complains only of irritation and some redness off and on. So having a high index of suspicion about the condition, but mostly in our country and in across the world is the diagnosis of OCP is missed by and large, and the delayed diagnosis is the rule. Slightly more than that can be an OCP which has moderately advanced with the inferior fornicel foreshortening and the surface changes, what you see. Rarely you may have a presentation like this. I had a gentleman, very, not in an age group where I would suspect OCP. So he presented with this kind of, so initially I thought that it's a conjunctivitis. Is a adenoviral conjunctivitis or something that is very acute. In few days he developed these lesions. And then we started thinking maybe it's a mucositis or it's a, maybe some form of SJS. He gave a history of fever. He gave a history of antibiotics. So for more or less, we started thinking that it's probably we are dealing with SJS, acute form of SJS or some subclinical form. Continued to treat him and also consulted a dermatologist who did the skin biopsy, and that was negative for pemphigus or other lesions. Then this is the follow-up over a period of time. This is 2 months follow-up, 3.5 months. So he improves, he was on systemic steroids. Then we started thinking, is it something that mucous membrane pemphigoid, and subsequently he underwent a biopsy, a conjunctival biopsy once the acute episode was over, and we settled on a diagnosis of OCP. And he has been under my care for almost 3-4 years now. He has moved to US. This is another patient where, in terms of the clinical appearance, you may not have much difficulty. The question about biopsy or not biopsy, Jim will deal with that, but I'll just show you that in this particular patient, biopsy was positive. This is the, again, you may have obvious scarring, but biopsy is likely, it was negative, and it is likely to be negative in at least 50 to 60% of cases. The second point is all of us need to develop a system of how you measure the progression, because in OCP, most important point is how do you measure the progression. Many of us just depend upon our clinical acumen, but better is to have a photographic documentation over a period of time, and that's been described in the literature, and Dr. Foster follows serial photography. I'll leave all these things out, and I'll just show you how the biopsy is done and what do you need. This is a OCT medium, which is for SNF freezing. When you take the biopsy, we putting the tissue immediately there, and then that flask is a liquid nitrogen, so you should put the cartridge. You should put the cartridge immediately so that it is frozen right away, and then a block is made. That block is then sifted to the the pathology lab, and there they have a cryostat machine with which you make the sectioning. And that's why yesterday I was telling that unless your pathologist or lab is dealing or able to deal with small samples, they would not be able to make sections or report a biopsy report for you. So, summary, because Vinay requested us to reduce 2 minutes or 3 minutes, so I made 5 minutes less. So, high index of suspicion, slow ongoing inflammation with subconjunctival scarring, immunosuppression cannot reverse what is already changed, and early diagnosis. How you do make the early diagnosis is either you are clinically very alert and have a backup of the lab that you biopsy. Otherwise, making a clinical diagnosis take much longer time. The cataract surgery in these patients is very good. Outcome is very good. Corneal surgeries, somehow they don't do very well unless you modify the technique or you really be prepared for complications. I have done few DSACs in these patients. They have done very well. Symblepharon management, I have about 5 or 7 patients where I have done the bulbar or the bulbar MMG to release the symblepharon, which was visually significant. If the symblepharon is not visually significant and not bothering patient, I would not touch or I won't do the surgery. Thank you very much.
Thank you, Dr. Sangwan, for that wonderful presentation. How necessary is it to do a biopsy before you say that this is OCP?
That question Jim is going to address in his talk, so I would leave that question to his talk.
So you can start treatment even on clinical suspicion?
Yes. Biopsy, the fear that biopsy can trigger inflammation, I think somewhere in the books and literature it's written, but I don't think that's a fear at all. So I would not think twice for taking the biopsy, except in situation like the acute presentation, which I showed you. In that situation, I would not be very willing to do a biopsy in that acute phase.
Why is it so?
Why is because the eye is too inflamed, and then there, you may give treatment anyway in such a kind of inflammation. You'll give aggressive treatment, and once somewhat the eye is settled, you can think of biopsy, or you can think of biopsy oral mucosa or skin, like we did in this patient, skin biopsy first.
Yeah, but that patient had mouth lesions, perfect for biopsy of the mouth.
Yeah.
It won't cause any problem, right?
I'll now invite Dr. Chodash to give his presentation.
Yes. While Jim is coming up, yes, Rashmi.
The pathologist at our hospital tells that you send the sample in Michel's medium, which is a transport. It will not, and then they do the frozen section possibly 12 to 24 hours later.
I'll
You do
address
not
that.
have the option of getting an OCT medium.
I'm going to address that in
Is
my
that
talk.
fine?
That Jim is going to address.
Okay.
So this is my last presentation of the meeting, and I wanted to take this opportunity to thank Dr. Sangwang and Dr. Mittal for this wonderful experience for me. And it's been a true pleasure and honor to be here with all of you among so many friends. So I'm going to briefly talk about management, but mostly I'm going to talk about diagnosis, because the management is, unless you think about diagnosis, the management is not really a relevant topic. I talked about this yesterday. I'm not going to go over it again, but I think in any patient which you're suspecting pemphigoid, you should always remember about drug-induced pemphigoid. It's very important because it may be a very different management. I don't think you need immunosuppressive medicines. Virender, you agree? And drug-induced pemphigoid? And then paraneoplastic pemphigoid is often forgotten because patients can have an occult cancer, and sometimes the presentation of pemphigoid can lead you as the ophthalmologist to find that. Linear IgA disease, I don't know how often you see that, but it's very treatable with dapsone, unlike pemphigoid. And then you have the other masquerades I talked to you about yesterday, and we'll just move through this. Okay, so let's talk about biopsy. This is really important, and I could hear the questions. This was an expert group, an eminence-based group, that got together in around 2000 and said, what is pemphigoid? Okay? And the group agreed that you should not call it pemphigoid unless you had a positive immunopathology for pemphigoid. Okay? The problem, though, is that we have patients, half of our patients have negative biopsy, even when we strongly suspect pemphigoid. So what do we do with those biopsy negative patients? This said, unless you have positive pathology, it's not pemphigoid. Okay? This is an example, Virender showed you an example of direct immunofluorescence. You're looking for immunoglobulins or C3. If there's IgA predominantly, that's IgA, linear IgA dermatosis. Okay. All right. But then, more recently, several papers came out. Okay, this paper from 2017. They showed that patients with negative and positive biopsies had the same outcome. They progressed in the same way. So clinically, it was the same disease. All right? And then this paper that just came out very recently, 2018, that suggested again that patients with negative and positive biopsies had similar outcomes. Okay? So should we defer treatment in a patient that has a negative biopsy? Should we repeatedly biopsy them? How do we manage that patient? This is a question that we get asked over and over and over again. Okay? Todd Margolis wrote, he used my term eminence-based medicine, which he failed to credit me. And then when he was reading the proofs, his wife was reading them with him. She said, oh, you didn't mention Jim's idea. So I always talk about eminence versus evidence, right?
So Todd called me up and he said, Jim, I'm so sorry I forgot to credit you. It's okay. But eminence-based guidelines, such as that 2002 recommendation, can be useful, but we lack evidence basis in this disease by and large. Okay? And Todd suggested that maybe we don't need to do a biopsy. Now, he told me later that he was just being, playing devil's advocate. He wanted to stimulate the discussion in his editorial. But I think maybe it didn't have the best effect because people are now thinking, well, I don't need to do a biopsy. I think it's pemphigoid, so just move on. Okay? We talked yesterday about the reason to do a biopsy being that you can find associated diseases in addition, or you can find masquerades. So why do a biopsy? I don't do a biopsy to deny immunomodulatory therapy. So I'm not doing a biopsy because if it's negative, I'm going to withhold therapy. Patients with a negative biopsy but with clinical criteria for pemphigoid should still be treated. Okay, that's very important. Don't do a biopsy and it's negative, say, oh, the biopsy's negative, I'm not going to treat this patient. If you think it's pemphigoid and the biopsy is negative, you should still treat, okay? But you do it to identify masquerade syndromes and coexisting conditions like atopy or ocular surface squamous neoplasia or a masquerade of a sebaceous cell carcinoma. That's why it's important to do a biopsy, okay? Now, when to do it? Any chronic conjunctivitis, when you see foreshortening or symblepharon and you don't have an obvious cause for those conditions, you don't have a history for SJS, a history for burn, a history for EKC, okay? So this is important. It was asked about what do you do? Verinder, you're showing the liquid nitrogen is great. The emphasis should be, if you take that biopsy and put it in saline and leave it on your shelf, after several hours, it becomes useless, okay? When I moved to Oklahoma after my fellowship, my then colleague he handed me all his pemphigoid patients, and 100% of them were biopsy negative. So I asked him, I said, how are you doing the biopsy? So he described perfectly how he takes the biopsy. Then I said, well, what do you do with it? He said, well, I leave it, and then at the end of my clinic, I drive it over to the hospital, which is nearby, where they have an immunopathologist, and the next morning, they process the biopsy, okay? 100% negative. That's how you get a negative biopsy. You leave it in saline for a few hours, or worse, overnight, and then the hospital processes it, okay? But Michelle's solution, which maybe Dr. Sangwon hasn't needed, is very useful. So what I used to do is put the specimen in Michelle's solution. It's not a fixative, it's a solution, okay? It's a mixture of ammonium sulfate and other buffers, but it can maintain the specimen. They claim for up to 5 days. I never left it. I would put it in the Michelle solution and then put it in a FedEx package, because I was sending at this point to another city where I had a really good pathologist who was used to doing renal specimens and renal transplant rejection, these sort of things. And we would FedEx it, so the next morning they would get the specimen, and the results were equal or exceeding what was published. Okay,
Jim,
so
now I'm going to use the same technique of Michelle medium, because in Shroff I don't have that ecosystem. It will take some time to build that, so which we are going to build eventually. At the moment, we are just starting with the Michelle medium and
So
sending it to LVP.
I still wanted to get it rapid transit because I was always nervous, what if 2 days is not as good as 1 day? And we have low rates of positive even when you know the patient has the disease. I didn't want to take any chances, but that worked very well. So Michelle's solution, it's not expensive and it's a very good thing. And you can keep it in your clinic at room temperature, and it's not a very expensive thing to maintain. So I agree with photographing these patients because our memories and our drawings are never as good as a photograph, but I don't personally rely on staging to determine progression of the disease. I look at inflammation. I think this is so important, that if you simply look for progression from one stage to the next, then you may have missed the window of opportunity to treat that patient. You may think the patient's stable because they haven't gotten to the next stage. But if they go from stage 3 to stage 4, you missed an opportunity to prevent that. And the way to prevent that is subconjunctival inflammation. The quiet eye typically does not progress. Or if it progresses, it's so slow that I think it's an acceptable progression. So that's my philosophy. Every pemphigoid patient, I look for subconjunctival redness and inflammation at every visit. I search the conjunctiva, and usually a treated patient will be quiet. Even though they have foreshortening and they have some symblepharon, If they're immune suppressed adequately, the conjunctiva looks quiet. So again, I showed this yesterday, you want to prevent a transition from the patient on your left to the patient on your right. Now, treatment strategies, people who are much smarter and more experienced than I am have developed various algorithms for doing this. Personally, I don't use dapsone in pemphigoid because I don't think it's effective enough. I think and most people will start a corticosteroid like prednisone or prednisolone orally and then place the patient on steroid-sparing therapy. Personally, I think that most cases don't need the prednisone. If it's a hot eye, absolutely, you may put them on prednisone and arrange for them to start cyclophosphamide. But most eyes, it's sort of a chronic indolent process. The patients had multiple lid surgeries because they have entropion. Nobody diagnosed the disease. They come in after years of this. It's slowly progressive. And I really like either azathioprine is what we used to use. I understand that mycophenolate is more expensive in India. But mycophenolate, in John Dart's review, had the best therapeutic index, meaning it had the lowest toxicity with the best effect of the oral agents. So mycophenolate is a great drug. You can use it for a long term. If it's too expensive, I personally like Imuran to start, and a lot of times we would start the patient on Imuran and never give them prednisone. So they never had to go through the prednisone-related blood pressure, weight gain, worry about ulcers, hip necrosis, all those serious side effects. Now, the drugs need to be monitored, but that's sort of my personal philosophy, but there are people out there who have treated many more cases than I have. For patients that are resistant to all therapies, the group in Boston, Rafi Ahmed and Steve Foster, have really shown that these patients, when treated with IVIG and rituximab, can do fantastic. You take a patient that's resistant to every immunosuppressive therapy and change to this, and the patient will quiet down. It's very, very, very effective if you can give it. And as I mentioned, though, in most cases, mycophenolate is sufficient. So in conclusion, the etiology of cicatricial conjunctivitis can often be discerned by history and slit lamp exam. Not one or the other, but both. Just as Mayumi was showing us cases, and Geetha said, well, I need more history. Again, these patients don't walk in a vacuum. The atopic patient, you could walk in and know that patient had atopic disease by the external exam even before you shake the patient's hand, right? You could see that was atopic disease, you knew that. The patient who ends up in the hospital for an acute illness with fever and ulcerations and skin loss, you know that patient had SJS, okay? And the patient with pemphigoid typically has no history at all, except many of them have had frequent lid surgeries for trichiasis, entropy, and other problems. That's a classic history for pemphigoid, okay? But you need both to make the diagnosis. I believe that all cases of chronic cicatrizing conjunctivitis should be biopsied to rule out other causes and rule in coexisting or masquerade diagnoses, okay? And immunomodulatory therapy should not be delayed or avoided if the demographics, meaning age, the history, again, I've just mentioned that to you, and examination suggests mucous membrane pemphigoid, even if direct immunofluorescence is negative and the biopsy is negative for other causes. These patients do just as poorly, you could say just as well, I think it's just as poorly as patients who are biopsy positive, and you should not hold therapy back from them. Thank you very much.
Thank you, Jim. Any questions?
Microphone over here, please.
For a new patient, a fresh patient who doesn't have inflammation and he walks into our clinic, who doesn't have any conjunctival inflammation, what do you suggest?
So a patient who comes in with, let's say, a little foreshortening and a symblepharon, and it's not bad and they're not very affected and you notice it, okay, and there's no inflammation, that might be a patient that I monitor. I agree with photographing patients, but if there's no inflammation, before I put them on therapy that might harm them, and all of these medicines have harm, all of them, and there's no inflammation, I would probably photograph them, see them in 2 months, and monitor them. And if there's no further progression, again, that patient might have had EKC and developed a symblepharon. And patients who have VKC untreated, EKC, will have isolated symblepharon and the conjunctiva is completely quiet. So that patient with no inflammation, I would photograph and follow as opposed to treating.
How frequently and when should we biopsy?
So I would biopsy a patient that has inflammation. How frequently to follow that particular case? You know, for me, it's usually, it's partly dependent on my level of concern and partly dependent on the patient's level of concern. But it wouldn't be uncommon for me to say, yeah, can you come back in 2 months? Let me check. I mean, you know, if you're watching the hour hand on the clock, if you watch it too quickly, it looks like it's not moving, right? So you want to give yourself a sufficient interval so that you could actually see some change. And I, you know, it's a guess, but 2 months would be what typical for me.
And a baseline photograph. And a baseline photograph for documentation.
Yeah, photography is very important. I agree. If you have that photograph, it eliminates your misremembering, or maybe your drawing is not accurate. Yeah.
How frequently do you see linear IgA as the diagnosis on biopsy in patients who present clinically as mucous membrane?
I personally haven't seen a linear IgA in over 10 years. And the ones that I've seen have had very distinct gum disease as well, not ulcers so much as like on near their teeth, which is characteristic. But I've probably only seen 3 or 4 linear IgA in my life. Now, I don't see the numbers that certain people see, but I think it's relatively, if pemphigoid is a rare disease, linear IgA is even more rare. But it's just, that's the reason to know it's linear IgA is because those patients seem to respond much better to dapsone than the traditional pemphigoid patient. So that would be the only case in which I would start dapsone personally, where I would not, you know, I don't like dapsone in pemphigoid because while you're waiting 6 weeks to see an effect, the pemphigoid patient may progress. So it makes me nervous.
So Dr. Sangwan, the same question to you. How many linear IgAs have you seen in your biopsy that you have done in patients where you clinically suspect OCP?
After coming to here in LVP, I have not seen a single patient. But in Dr. Foster's practice, I have seen a few, but very, very uncommon, very uncommon.
It's uncommon.
So most of the patients are either biopsy positive OCP or biopsy negative patients where we start them on treatment based on our clinical impression.
Correct.
And how many times has histopathology helped you differentiate a clinically evident OCP from one of the other differentials that we're looking for on histology?
You know, I don't know a number. But the way I look at it is if it's 1 in 100 and the person had a carcinoma, for example, that's really an important number. So, you know, you always talk about number needed to treat, number needed to harm. That's a very useful concept that you can determine in clinical trials. We don't have clinical trial data, but the number needed to harm is extremely high with a conjunctival biopsy. As Virender said, if the eye is very hot, you may not want to biopsy the conjunctiva, you may go to the mouth. But if the eye is not quite so hot as that acute phase, and I've seen those cases also, then the morbidity from a conjunctival biopsy is extremely low. So my number needed to harm, the number of biopsies I would need to do to harm one person is extremely high. So the downside of doing a biopsy is very low. The number, so even if it's 1 in 100, even if it's 1 in 500, maybe even if it's 1 in 1,000, I still want that biopsy. Now, the number of patients with signs for atopy, like if, you know, I get a lot of patients now from Steve Foster, and a substantial number of them have had atopy identified by his histopathology. Okay, so that's been helpful in the management of those patients. And the ones that have, at 5 out of, what did I say, about 10% of patients will have dysplasia. I'm still debating in my mind whether that needs specific treatment for dysplasia, but it's an open question. I certainly want to know if there's dysplasia on the biopsy. I may follow that patient a little bit more closely, looking for changes in the surface epithelium than a patient who has no dysplasia on the biopsy.
Wouldn't the biopsy have a better yield in an
just
inflamed?
on that point, what has been very helpful in Hyderabad for me, I had a very good skin specialist with whom I would collaborate. And 2 or 3 occasions I remember where to me clinically looked like OCP, my biopsy was negative, and when I sent him to, he diagnosed with the skin biopsy is the pemphigus vulgaris or pemphigus, some 2 or 3 cases I remember.
Yeah.
That's exactly what we do too. We have a good dermatologist whom we collaborate with, with whom we discuss when we have these cases, and they also examine the patient to see whether it would fit into OCP or one of the other vesiculobullous diseases that could be a differential diagnosis in these. The question that I was asking was, would biopsy in an inflamed eye have a higher positive yield than in an absolutely quiet eye?
No, both the absolute quiet eye also, well, I was just waiting for Asi was asking that if you have a quiet eye, only fibrosis and no other evidence. So in that situation, you ask question to the patient, has your eye been recurrently red? Do you have episode of redness in the past? And if they are having difficulty in recollecting, means they don't have, they did not have. So in those cases, you don't want to do biopsy, you just observe. But if the patient has a, like what I showed you the patient, and I have few patients like that, and a very younger patient. So they don't fit into the OCP age group, but we did find them later on as a OCP. So a very acute like this, doing biopsy in that phase, if you are able to do, I think it's okay. Harm would not be, I mean, it's already so inflamed, what more you can cause? Yield, I don't know. See, because the biopsy, these cases are not that very often.
Yeah, they're
Acute,
rare.
The acute onset of OCP is not very often.
Yeah, so I had a patient very similar to Virender's. He was 33 years old, and he came in with these incredibly angry eyes. He already had some foreshortening inferiorly, and I looked at him and I thought, oh, this is too young. But he had some mouth lesions, and we got an oral biopsy which was positive. And those are the patients that can progress very rapidly to blindness. So it's very important that you sort of keep in mind when you see those hot eyes. And to me, you wouldn't make the diagnosis of pemphigoid if the fornices and everything were normal. You have to see some evidence of fibrosis somewhere on the exam in order to trigger that. The problem is not that so much. It's the patients that have on and off inflammation, smoldering, who have foreshortening and symblepharon, and no one ever makes the diagnosis. And they come to you after years of various eye surgeries and different medications, and no one has thought, wow, this could be pemphigoid. That drives me insane, because you see the patient, you're like, look at that foreshortening, it's so obvious. And the doctor's saying, oh, it's idiopathic. They never actually, you know, it's like everything else. If you don't think about it, you'll never see it. You know, maybe you've seen this, Virender. There's a great video where you're supposed to watch these people bounce a ball and count the number of times the ball bounces, and you watch it for like 5 minutes, and everyone's counting, because it's a test. And then later, they show you a segment of the video where a guy in a gorilla suit walks through the scene. No one ever sees it. They're only watching the ball bounce. And if you don't think about pemphigoid, you'll never identify it. So our job, our education, our foundation is to recognize certain things that we have to look for. If you don't look for it, you'll never find it. So every time you got to look, if you see foreshortening, you see some symblepharon, it should immediately trigger, what is this, right? I think the people in this audience know that. But the average person seeing patients, at least in my part of the world, it's amazing how often it's missed. It's very disturbing.
You said that irrespective of whether the biopsy comes positive or negative, the protocol is that we should start the immunosuppression if you're clinically suspecting. So how do we explain that to the patient? Like when we are telling him that we need a biopsy and, you know.
I explain it just the way I did to you. I say the biopsy has a low positivity rate. If it's positive, we're both very comfortable, but there's a high negative rate, but we're not doing it just to rule in, to rule in pemphigoid. We're doing it to rule out coexistent or masquerade syndromes that might change your treatment. So I used to have this difficulty, and with these recent papers, it really triggered me to think about it in a different way. I actually always sent the patient for biopsy, but I always had this discomfort, like, how do I explain to the patient? Now I have no problem.
And also, Susmita, look at the context. See, as a clinician, think more, don't depend only on the lab. Ask little more history, how the eye is appearing. Can it be an episode of chemical burn? Can it be an episode of healed EKC? Is he on medication? See, all those things. The one test is not going to help you just to pin down, rule in or rule out.
Yeah.
So as you know, there's a significant recurrence rate with entropion and symblepharon in these patients. So when do you refer for symblepharon or entropion repair? And then do you recommend perioperative steroids or immune suppression around the time of that surgery?
So it's an important question. So these patients should not have eyelid or conjunctival surgery until or unless they are controlled, which means they're typically on therapy. Now the question comes then, if the patient's on therapy and they're controlled, I don't think that you need to further bolus them for surgery, personally. They're quiet, and they're already gotten their bolus, except it's chronic therapy, okay? The question is, if you have a patient with, quote, burnt out, I don't really know if that exists. I always worry, if you read Dr. Foster's literature, after stopping medicine, 1/3 of patients had recurrence, okay? I have a little bit different take. When I read that literature, I thought, that's too high. So I like to ask the rheumatologist who's ever giving the medicine to maintain that patient on a very low amount of immune suppression. In those patients, I have not had major recurrences, okay? So if they're on CellCept, you can dose that way down, and the patient has very few side effects, okay? And then I think they're much less likely to recur. It's the patient that's completely off medication, who may leave your practice because they think, I'm fine now, who gets those recurrences. 1/3 is very high. And remember, when they recur, they typically lose more vision. So I don't want to have, I want 0 recurrences. So the patient that's off therapy completely, in that patient, yes, I would say that's a reasonable thing to do, to give them some therapy at the time of surgery or just before. But most of my patients are maintained on some level, even very low dose therapy, for the long term. Because I don't want to see 30% recurrence.
Yeah, that's interesting, because a lot of times they'll send them to me once they're stable, and maybe they still are on treatment. And then we'll do the surgery, they'll do great, and then 2 years later they'll come back to me with recurrence because they've stopped, they don't have entropion anymore, they're stable, and so their immunologist or whoever's giving the medication doesn't see a reason to continue it, but then the symblepharon comes back. So you're saying they need to be on maintenance.
It's my personal, I don't have any data. Verinder, do you stop the therapy when they're quiet, or do you continue?
I'll continue, at least I follow at least 9 to 12 months with no recurrence. And if they need surgery, entropion surgery or cataract surgery, I'll just do surgery in that period on when they are on maintenance dose.
And then my last question is, how long of them being stable? You know, do you wait 6 months of them being quiet? Or is there a particular timeline?
You mean when you can operate?
Yeah.
I mean, I think if they're quiet, they're quiet. And you can operate when they're quiet. You know, if there's no subconjunctival inflammation, there's no, I don't know that, I lack evidence to say that 2 months is different from 6 months.
No, this is like, you know, for uveitis, intraocular inflammation, we go by not, this is not like an evidence, but it's a rule of thumb is that we, at least 3 months of a quiet eye, then we can think of doing any surgery with the maintenance dose of drug which they are already on. So I would think the same thing that you can follow.
Yeah, these are arbitrary, empirical, you know, eminence-based guidelines.
But if you say it, then I'm going to do it.
So, yes.
If I'm thinking of a diagnosis of OCP and I want to take a biopsy, so number one, whether in the acute inflamed stage where I am suspecting it, shall I opt for biopsy or shall I wait for the inflammation to subside? Number two, the site, the preferable site where I want to take a biopsy which might not lead to further complications or further shortening of fornices or anything like that.
So the question is, should you wait till the disease is quiet to do the biopsy? No. You should do the biopsy when the disease is active. If you wait until it's quiet, the biopsy will be negative, and there's almost no point because you've given the medicine. Okay? So the second question is, as we discussed, bulbar conjunctiva, preferably on the nasal side. That's based on empirical evidence from Dr. Foster. I don't think that, in my experience, biopsy has not worsened the disease. I can't think of a single patient in whom the biopsy clearly led to worsened disease or disease in the same location as the biopsy was taken. You know, I think it's a minor insult. Now, eyelid surgery is not a minor insult in the pemphigoid patient, and that's where you see patients get in trouble. The last time I operated on a patient where I didn't know it was pemphigoid, I regretted because the patient had major inflammation afterwards and got much worse.
He has been waiting for a long time.
Oh,
nobody's
okay.
looking at him.
Well, what I've seen it helps is indirect immunofluorescence. So basically, the same day we take the biopsy, we draw blood, and we have like a kit for immunofluorescence. So basically, it's for the blood for the indirect immunofluorescence. I've seen patients that are negative on the direct, and they're positive on the indirect.
Yeah, we didn't talk about immunoperoxidase today, but Verinder mentioned it the other day. I mean, there are a variety of methods to enhance the positive rate. That, to me, is up to the pathologist. But again, I'm happy if I'm not happy the patient has pemphigoid. I'm happy in a patient that I know has pemphigoid when the biopsy is positive for pemphigoid and only pemphigoid, because then it makes a very clear path. It's easy to explain to the patient, all right? But if the biopsy is negative, I'm happy for the pathologist to do whatever they need to do. And usually, so because I'm going to treat whether the biopsy is positive or not, I'm less worried about enhancing the positive rate as I am about other causes and other coexisting diagnoses, which my second, see, I'm going to take 2 biopsies, 2 small biopsies. One goes in formalin, one goes in Michelle's. And that way we have this way to determine A to P, cancer, all these other things. Does that make sense? Yeah.
And what is the ideal size of the biopsy?
Say again?
Ideal size of the biopsy. What
nasal bulbar conjunctiva.
Size.
Size.
How much tissue should
What is
you
the
say?
ideal size?
You know, 2 millimeters or 1 to 2 millimeters. I mean, you need a piece so that they don't lose it. I don't know. Verinder, what size?
Can I
2 to
request
3?
the next speaker to be ready in the meantime?
I didn't hear that.
No, that's for the next speaker to be ready.
Good.
No, you can continue.
I just had a comment and a
Darren,
question.
Last question.
I got the same. I've biopsied dozens of these patients. I've never seen it lead to, inflammation or flare up.
Yeah.
And I think the textbooks used to suggest that. I felt the same when I remember when I did my first biopsy. I was scared to death. Like, oh no, I'm going to make this person so much worse because that's what the textbook said. The same when I first started taking care of acute Stephen Johnson patients. They all said to find a glass rod and break the
glass
symblepharon.
rodding is, to me, that's the most useless thing to do.
Yeah, I remember being so stressed.
Yeah, that's like in the textbook.
I didn't know where the heck do I find a glass rod. Yeah.
Eminence-based. Somebody like me stands up and says it, and all of you assume it's true. Don't ever do that.
Yeah.
Question everything you're told. Everything.
Yeah, I never
Examine.
believe anything you say, Jim. It's good.
No, but
my other question for Virender and Jim
Yeah.
real quick is your experience with K-pros. You said that a full thickness transplant struggles in pemphigoid. Is the K-pro experience with pemphigoid difficult as with Stephen Johnson, or is it better?
I think equally difficult. Equally difficult.
Yeah.
Don't do it unless you have to.
Yeah, I follow that in SJS and OCP, the traditional type 1 K-Pro, not a good idea.
So in pemphigoid, the results are the worst that we see for type 1 K-Pro. Okay, the worst. And I refuse to do type 1 K-Pro in pemphigoid. I have a few patients with SJS. We saw one yesterday. If you're very dedicated to managing that patient and they have perfect tear film and lids, again, you can achieve success, but you be prepared to replace the K-Pro, to see the patient urgently. You will see infections, you'll see melts. And if you're willing to tolerate all of that and see the patient and you see them frequently enough, you can maintain vision for quite a few years where otherwise they would be blind. But it's a big undertaking, and you have to have just the right patient to do it in.
Thank you.
So I'm going to just transit from OCP to SJS. Neera, you're going to, or shall I just start? I think Neera is, yeah. So this is about Allo-SLET in SJS, and since we're talking about OCP, I thought I will, our experience with Allo-SLET actually began with Allo-SLET in OCP. Dr. Sangwan, I can see you going off, but I just no, I just wanted to ask you one question before I actually start as to what has been, have you done Allo-SLETs in SJS? I'm not talking about OCP, in SJS patients, and because we have a very limited experience, I'm just going to show you the...
Allo-SLET, SLET I have not done, but Limbal transplantation in SJS I did in 2001, 2002, without doing what we are doing now. And my experience was so bad that after 5-6 cases, I stopped doing. And only now, I have not done, but Sayan has shown me one case that he, after MMG, lid margin MMG and the MSGT, and he's got a very nice result.
Right. So I think again a disclaimer at the start of the case that these are not cases that we do routinely or recommend routinely. We did Allo-SLET in OCP for 6 eyes, of which 4 of them are doing well over a 2 to 4 year follow-up. These were patients whose OCP was controlled with systemic mycophenolate, following which we did the Allo-SLET in eyes that were moist without any underlying corneal scar that would subsequently require a keratoplasty. And this was in fact one of our first patients on the right side of the panel. She was an 80-year-old female for whom we did, whom we had planned a type 2 keratoprosthesis, but then we initially did Allo-SLET in one eye. You can see the outcome over a 4-year follow-up. She had relatively clear corneas beneath, which was what was responsible for the fact that she did have some amount of visual improvement, but then at 80 she also had ARMD. Now vision did not improve too much, and so possibly it was a good decision that we really didn't do a type 2 K-Pro in her. And these were all patients who were only on mycophenolate and no other immunosuppression, and the surface did hold on over the period of follow-up. So when we had a few of these patients of OCP that we did the Allo-SLET for, and we had, I showed you yesterday that we had done Allo-SLET in some of the patients who had semi-acute SJS. We decided to do Allo-SLET in chronic SJS. We've done it in 3 eyes of 2 patients that I will show you. It's only in moist eyes. We knew we had to deal with the issue of long-term immunosuppression, because here in these subset of patients, unlike OCP who are already on mycophenolate to keep their disease under control, these are not patients whom we routinely start on immunosuppression. There was again the question of what the ideal immunosuppressive regimen would be, and these are eyes where you have to stabilize the ocular surface whenever required with a punctal cautery or mucous membrane grafting for lid margin keratinization. So we decided to, I mean, this was a child. The reason why we were pushed into doing this Allo-SLET was 8-year-old child, bilateral with moist eyes, where you don't really have any other option to improve the vision. And we decided to go ahead with the Allo-SLET in the first eye with systemic steroids and mycophenolate. That was the only immunosuppression that we gave him. And this is his post-operative picture. 6 or 7 months later, there's a focal conjunctivilization that you can see coming in from the inferotemporal quadrant. And we addressed that at the same time that we also took him up for the Allo-SLET in the other eye. So the Allo-SLETs were done because of the good result that we had in one eye. We did it in the other eye also. And this patient, over a period of follow-up, that's 13 months for the first eye and 7 months for the second eye, we've been able to maintain a good visual acuity in both the eyes with only mycophenolate as the immunosuppression that we are giving in these patients. This is the second one, again a child, where we did the Allo-SLET in one eye. This patient was not, I think, not able to tolerate mycophenolate, so he's only on systemic steroids and actually azathioprin. And over a period of 5 months, you can see a gradual conjunctivilization coming in. He improved to a visual acuity of 612. But then this is at 6 months post-operative where the conjunctivilization has progressed. We were thinking of repeating an Allo-SLET and probably increasing the immunosuppressive drug regimen the second time if required, to add on cyclosporine along with the mycophenolate, along with the azathioprin. And but as of now, he's still able to be self-ambulatory, so we have not done any further intervention. So that's our experience, 3 eyes in 2 patients of chronic Stevens-Johnson syndrome. And I think the 2 areas that we are concerned about, one is immunosuppression for Allo-SLET. Whenever we do an allo-limbal graft, we always talk about a 3-drug immunosuppression, but the only thing was, since we saw the outcomes in our patients of OCP with just mycophenolate, we decided to adopt the same immunosuppressive strategy for these patients of SJS. And also the fact that you're placing the allo cells on an avascular cornea and not the limbus, probably the need for immunosuppression is not as stringent as what it is for a limbal allograft. but we need more experience and more understanding of this situation to be able to tell definitely as to what the immunosuppressive regimen would be for these eyes. And the second would be donor selection. Is live related more preferable, either from a sibling or a parent? All the eyes that we did for in OCP and the 3 that we have done in SJS have all been cadaveric donor transplants. We have not done a live related, but probably if there is the option of getting a live related donor, that might be preferable with respect to reducing the risk of rejection. So I think that's all that I have to share with respect to Allo-SLET in these 2 conditions. Thank you.
Thank you, Dr. Geeta. Very specific, restricted questions now. Yeah, please.
Dr. Geeta, excellent as usual. Just one question, that is, would this number of explants and size of explants be a limiting factor when you take live related versus cadaveric? Would that have an impact on the results?
I don't think so. In fact, I would feel that the placement of the implants shouldn't be too peripheral. It should probably be in the mid-periphery, because your vascularization as well as your dendritic cells are more in the peripheral cornea, which is what is ultimately responsible for the rejection in these grafts. But you will limit the number of the pieces that you place.
No, but
and I don't think
the
there
question,
is a difference between the number of pieces that you would take or the size of the graft that you would take from a live related versus a cadaveric.
The question,
unless you have a difference of opinion.
Her question was cadaveric versus live.
Yes, will there be a difference in the size of the graft and the number of pieces? I don't
outcome,
think so.
Outcome, there will be difference. I mean, at least in the lab, what we have seen is that the cadaveric, the cells growth from the cadaveric is much lower than in the live. Say the paper we have published is about 50% or 42% cadaveric versus 100% live.
What is your experience, Dr. Geeta?
No, we have not done live related in any of these eyes. So our experience is only with the cadaveric donor.
So in your experience, cadaveric, the lab may say 50, but in your experience, cadaveric does a reasonably good job when done in situ.
Yes. But the only thing is it should be a fresh tissue.
That's
we don't
fair.
want, So the usual things that we follow for a cadaveric donor graft.
Does the question is, would the amount of immunosuppression required vary whether it is cadaveric
In fact,
or
the amount of immunosuppression that we have used is not the typical 3-drug regimen, and we have used a slightly lower regimen. We don't know whether Allo-SLET by itself requires a lower immunosuppressive regimen than a typical limbal allograft that we used to do earlier.
I think it would be less, based on what we understand from the biology of the SLET and the mesenchymal cells that come with it. And the amount of tissue that you are using is much less. You are putting it on the cornea, not in the vascularized limbus. So all those in that paper that we have mentioned, that probably we don't have evidence, but looks like the amount of immunosuppression needed will be much less.
Yeah, see, our largest experience with cadaveric Allo-SLET has been in that subset of acute chemical injuries. I wouldn't want to really compare the reasons and the pathophysiology behind the two, because they're probably two different things altogether. But based on the experience that we had there with absolutely no immunosuppression and seeing good results in some of the patients, we decided to go ahead with a reduced immunosuppressive regimen in these eyes. And we started off with OCP, where these are patients who already need immunosuppression, and then did the Allo-SLET. And based on the results that we saw in 6 eyes of patients with OCP, we went on to start the Allo-SLET in chronic SJS. But then there are a lot of criteria which have to be fulfilled before you take up these patients for an Allo-SLET, because otherwise the risk of failure is very high. Thank you.
Thank you.
Geeta, one question for me. Geeta, so you took the other eye of that child, I think 6 months after the first eye. So my question is, from rejection point of view, from immunosuppression point of view, do you feel that there should be some gap when we take up the second eye, like when we do a full thickness penetrating keratoplasty? You know, we know that we should wait for some time before you take up the other eye. Here we are already given immunosuppression. So is it that your thought process was because the child is already on immunosuppression, and during that particular period window
Yes.
that you want to use for that?
So probably, I mean, we obviously didn't want to do it too close together, and it was already 6 months since we had done the first graft, so then we took up the patient subsequently. So probably 6 months to maybe a year after you have done the first. See, we wouldn't have really thought of doing a bilateral Allo-SLET, but this was a child, both eyes affected severely. We had a very good outcome in one eye, which is why we even decided to extrapolate it to the other eye. But then sometimes in adults who fit into all these criteria, maybe you would just do an Allo-SLET in one eye and leave the other eye for a later date.
Because I have done, when I was doing allo, cultivated allo, I have done both eyes simultaneously, and they have done equally well. And the number is very small. Same donor, yes. Yeah, so if you do simultaneously, same donor. If you do at the same time.
So if it's a bilateral, you have to do both
bilateral,
the eyes
yes.
on the same day.
Yeah,
the
same day.
donor.
I mean, I have done this, in the same setting, same sitting as two different eyes.
Yeah. So that way you're exposing the system to only one allo antigen.
Good morning, everyone. We all know what SJS is. I'll talk about a 68-year-old male who had a history of mucocutaneous rashes, ulcerated oral mucosa, along with conjunctival sloughing. He was diagnosed to have Stevens-Johnson syndrome following use of indomethacin, and he presented to our hospital after treatment of acute phase. He had both eyes conjunctival congestion along with mucus discharge. He was still maintained on topical medications, topical cyclosporin, with addition of topical steroids for the acute inflammatory episodes. However, the ocular surface, since it was very poor and the keratinization increased, so we considered buccal mucous membrane graft for the left eye. The right eye, for the presence of cataract, patient underwent phacoemulsification with IOL implant. However, even after undergoing a buccal mucous membrane graft, the ocular surface continued to worsen. The inflammation slowly progressed with progression of symplifron, obliteration of fornices, and visual acuity in the left eye continued to deteriorate and was counting fingers. Over the subsequent 5 years, the left eye had fornicial shortening, complete symplifron, keratinization of cornea. Right eye also started showing changes of fornicial shortening with symplifron. However, the cornea was not as bad as in the left eye. So, since there was more of fibrosis and cicatricial changes, so we suspected that either a coexistent OCP or a transformation of OCP was there. Hence, the patient was started on systemic immunosuppression. Initially, we started on methotrexate, 25 milligram. However, due to poor response, we switched over to cyclophosphamide, 50 milligram, which was maintained with a tapering dose of Deflacort. The inflammation started to reduce. However, we had to discontinue because patient had hematuria. Finally, the patient was started on mycophenolate, 500 milligram BD. The initial response to mycophenolate was also poor. So the dose was adjusted and increased slowly. Now, since around 2 years, the patient's ocular surface is stable and he is being maintained on mycophenolate systemically along with topical medications. We all know aggressive management is essential to reduce disease progression, and systemic corticoids, we all know, have a role in ocular disease, but they are not acceptable for long-term use. Systemic immunosuppression has been used successfully in many cases of persistent ocular inflammation. There have also been reports of mucous membrane pemphigoid occurring as a sequel of SJS, which obviously benefit from systemic immunosuppression. In our case, we really don't know whether it was OCP that was going on or whether it was a progressive form of SJS. But clinically, we suspected because of the cicatricial changes and the patient stabilized with immunosuppression, that probably it is OCP. So on the clinical features, we started the patient of immunosuppression. So whether it was progressive form of SJS or OCP is still the question.
Any questions for her?
Obviously, as we know, systemic, that clinical progression.
Thank you.
I think, debate whether it is SJS or OCP, and sometimes it becomes essential to label whether it is OCP or SJS, not because that it will be of management, big management problem, but also sometimes from social point of view, because this patient is a head of a large religious sect, and every time 4 or 5 people used to come with him to find out what he is suffering from. So this was his history, that he had for the last 2 years he had recurrent attacks of pain, redness, watering off and on. And according to him, all this problem started after taking analgesic, but there were no details available. He had no mucocutaneous or skin lesions or scars available to him. He was not even admitted to the hospital for that. And he also complained of dryness of mouth, no joint pains. There's no history of any systemic illness. Since it was in 2004, he came to us, so we also had some problems in photographs. This was his clinical picture. Visual acuity in right eye was 460, left eye was 660, and Sherman readings, both eyes were 0. Mild conjunctival congestion. Then both eyes had central corneal scars with superficial vascularization, no furnitures or shortening, only SPK. He has been treated for dry eye previously for the last 2 years. Now this is what was when he came to us. So when I examined him, I thought it's he's having dry eye, but it's something more than dry eye, because simple dry eye for 2 years will not lead to this kind of presentation. He had dryness of mouth, so could it be Sjogren? And history of drug intake, all problems started, so could it be Steven Johnson? Recurrent herpes simplex keratitis, bilateral, very rare. We have seen few cases, but then history of recurrences and all that is usually there. This thing we did not consider. So it was mainly considered Steven Johnson syndrome. All the investigations, they were negative. Any other diagnosis we could entertain at this stage? Any possibility, because it's the history of drug intake is just the yeah. Pardon, sir?
Did you check for any oral lesions?
No oral lesion, no skin lesions.
No, did you look in his mouth? So it's important to look in the mouth of patients when you suspect pemphigoid. You should look, because the patient may not be aware. And you just need a pen light, and you often can see pemphigoid lesions in the mouth.
In the follow-up, we had just treatment for dry eye. There is something interesting during his follow-up. We did not give him any immune suppression. It was on and off. Whenever he had some acute exacerbation, we give him systemic steroids for a short period. And for the period from 2009 to 2011, he had reasonably good vision, 624 in the right eye and 636 in the left eye. Then there was some inflammation, and vision decreased. So we again treated with systemic steroids, but it was in 2012 that we thought that let's see whether we are dealing with SJS only or it is something else. So we thought we will, and there was some scarring also developing at that stage. So we went for the conjunctival biopsy for this patient. And the conjunctival biopsy for this patient was negative. So my question is, should we keep this patient as still Sjogren or SJS or OCP?
He has the acute onset episode of SJS. No.
I didn't follow.
Acute onset of, no.
Did this patient have an acute onset or no?
He had acute exacerbations during follow-up. And at the onset, he says it all started after taking that medicine.
Look, Mayumi, the history is a little vague. There has been, as far as the patient's history, maybe it started after some drug intake, but he has had intermittent acute exacerbations during his follow-up.
No acute onset of the skin eruption. No. Also that, no, it's yes.
So the thing is that
there are So this is, I think, where we were at crossroads, should we immune suppress or not? But then I think he didn't come for follow-up since long, but still I feel that once he comes, should we immune suppress him now? Now his vision is down, because earlier he was having good vision.
See, now with the immunosuppression, unless your goal is to make him more comfortable, the visual improvement may not be a very significant, unless you try Prose lens. Prose lens may give some
or should we have immune suppress from day one for such a patient where there is no significant?
I would have done that.
I think if I would probably do similar, but the only difference is maybe in a clinical scenario, I would have waited for the first acute exacerbation. At least at that stage, immunosuppression would have been a definite option. And oral steroids is not the way I would have gone.
And any experience on anti-VEGFs? There are 1 or 2 reports in the literature for acute exacerbations, anti-VEGFs or something.
Those are, that's very cosmetic.
Actually, in fact, anti-VEGF injections are, if you have OCP as one of your differential diagnoses, there should be absolutely no manipulation of the conjunctiva without your immunosuppressive cover. So even we've had instances where patients have been given subconjunctival Avastin elsewhere in patients with OCP where they've come up with a severe flare-up after that. So I don't think you should meddle around with the conjunctiva for any reason whatsoever in a patient where you're suspecting OCP. In a patient who does not have typical skin lesions, oral mucosal lesions where the drug appears to be only incidental, where you have recurrent exacerbations and there is a continued progression of the cicatricial changes, that's the right way to go ahead with a conjunctival biopsy. But if it's negative, I think we need to start the patient on systemic immunosuppression.
Why I'm asking is because there is one report, I think, which has shown that in acute SJS patient was having very severe photophobia. They have given anti-VEGF and patient has responded. And one of the patients brought me this information. So I was a little bit concerned.
The use of VEGF in Stevens-Johnson syndrome and in OCP is probably different. You don't want to give a subconjunctival injection in a patient with OCP.
And Ashok, even if you think about it, see, these are very transient and the underlying problem is going to continue.
No, so I don't believe it. I was just asking because...
In fact, take a step back. Forget that it is VEGF. Any drug given subconjunctivally, just look at the whole pathophysiology of how long does it last inside that area. Would it be there long enough for it to achieve any effect? So forget whether it is VEGF or, as Geeta said, anything.
I will take another minute for the next patient. This is the child. And he had a definite Stevens-Johnson syndrome, and his acute stage was treated in a tertiary care center. To us, he came at a stage when he had epithelial defects in both eyes, and then we did amniotic membrane transplant, symblepharon release, and then he was okay for next years with, of course, acute exacerbations. And this is his right eye. We tried even mini-scleral contact lens for him, but there was no much improvement. There's no lid margin keratinization. This is the latest picture now. And now at the moment he's developing mild superior symblepharon with some pannus on the superior side and inferior symblepharon also. I would like to know at this stage what treatment we should do for him. This is his better eye. And this fellow is able to study. Of course, he has a writer for him. He is now 18 or 19 years old. And he is the one who can drive motorcycle. He can drive even tractor also. He is socially well adjusted. Any suggestions for the treatment of right eye? This I'm asking because the thing is that somebody asked yesterday that we tell the patient and patient doesn't accept the treatment. I want to be very clear for myself. Any treatment for him, If it is going to be of any benefit, then only we can suggest him. Of course, we have a very long-term follow-up of 15 years association with the patient. If we tell him something, he is going to accept. But I think our treatment should not harm him.
I'm not sure of how moist the eye is, what is the status of the punctum, and to the extent that we are able to see on the picture there does seem to be some amount of lid margin changes. The inferior half of the cornea is probably what is clearer, which is the reason why he's still self-ambulatory. And I think if this much amount of phonics is not able to help you fit a PROS lens in the eye, then some amount of, after you have done a punctal cautery, if there is a patent punctum and dry eye, then we can consider minimally releasing the symblepharon and addressing the lower lid margin changes with the mucous membrane graft. In fact, when you do that, your inferior phonics will also increase a little bit, and you place a PROS lens, which should probably help him. A type 1 K Pro in this patient with SJS probably not indicated.
No.
I have a question for answer also probably. One thing is I feel there is significant inflammation which is there. So if this patient is having intermittent bouts of inflammation.
Not really.
No.
He during 15 years, he had not significant inflammation for which we have to bother, like the previous patient had. So because once these patients they will have epithelial problem also simultaneously.
So the second
So
part is
again the question comes the same thing, if we have immune suppressed him, we should have immune suppressed him for 15 years.
Fair enough.
So that's a big this thing.
The other part is the question about using miniscleral lenses. Depends on what is the aim with which you are looking at it. If you're looking at visual improvement, obviously in this kind of a scenario, visual improvement
Yeah,
is unlikely.
definitely. He's symptomatically, he's perfect. He doesn't have any
So if
symptoms.
the patient is asymptomatic
Yeah.
and he is ambulatory,
Yeah.
then to try and do
No.
anything further in terms of surgical intervention, which has a high risk of failure,
Yeah.
would not be a
Now
advice.
coming to the next, his left eye. Now left eye is worse. He's having hand movements only, and he has mild lid margin keratinization also from the temporal side, but it's limited, it's not progressing. He has symblepharon also superior, has inferior.
So can I mean, you told us the essential information. You told us he was well adjusted, driving his motorcycle, doing everything. This is not a patient I would offer surgery to. The bad eye, I would tell him that, what's the word for spare tire?
Stepney.
Stepney. Okay, I need to learn that word. So that's what you do. You make sure that the pressure is maintained in the low normal level in the
pressures are maintained
in the Stepney eye, and then you just keep him as quiet as possible, because when the patient is well adjusted, you can ruin that by offering anything, even something with a relatively low complication rate. If that particular patient has that even uncommon complication, you will regret till the day you die that you offered him an intervention.
At present scenario, seeing his all status and everything, is there any surgical intervention? Should we advise him in the left eye?
That's what we are saying, that if he's well adjusted and he's happy, ambulatory, and he's happy what he wants, he's doing, I would really not offer him anything other than maintaining his status quo. And many a times we physicians and surgeons have the pressure of doing something because he's coming, and we are seeing something. The underlying theme is, if patient is happy with the current situation and he says, yeah, mera zindagi acha chal raha hai, then I don't think you should try to answer any of those things.
Sir, this is the situation, like we can see only lower part of the cornea is spared and he is surviving because of that. So the pressure can occur in other way also, because if we will not save that much of cornea, then his routine life, because how long?
Yes, I understand. But my argument is, that is a pressure and you're feeling that if it destroys, then what will happen? My argument is, you do not have a very good option to save that, because anything you do will accelerate the problem. So allow the patient to function the way it is. It may be 4 years, 5 years, 3 years, and if it goes bad, then you have much better risk-benefit ratio, right?
Right.
Then you will have a, okay, now I have lost everything. Now I can do intervention which will justify these aggressive surgeries.
Right. The most important thing is treat the patient, not the physician. It's not about how you feel. It's about what the patient feels. You told us the patient is well adjusted. There's no indication for doing anything unless you have a therapy that is not going to make this worse. And I would predict anything you do to this ocular surface is likely to make it worse. So in the short term. So as Verinder said, we don't have a good option to prevent progression. He's happy. Let him enjoy his life without being in your office every week. Okay? And then if it worsens, then you can address whatever options are available.
Yeah. I think, thank you. Any other
Dr. Geeta, I have this question. So you said that we can do a lid margin MMG and then maybe a simplifron release and try and fit the BOSP. So here we would be doing the lid margin MMG and the simplifron only if we are planning to fit the pros. That's the indication here, so that we get because otherwise doing an MMG
The only issue here is, I mean, even the reason why I suggested a surgical intervention is the contribution of the lid margin changes to the progression of the corneal vascularization, and since you have only a small island of cornea that's still clear, we need to take a decision as to whether you want to intervene or not. If he's been the same since the day you saw him, and there's never been a progression of the corneal opacity and the vascularization, you could probably just hold on and watch. But if you think that there is a certain that there's been, this whole thing has been coming down significantly over the past few years, which can be attributed to the blink-related microtrauma that's caused by the lid margin keratinization, then to salvage the residual part of the clear cornea, you would consider doing a limited phonics reconstruction with the mucous membrane grafting, probably if or not you decide to go ahead with a PROS. This is only to prevent a further progression. But again, that decision has to be taken based on the progression of the condition over the last few years.
So Geeta, so I agree with you, but also we haven't seen fluorescein staining. So let's say that this patient has no fluorescein staining.
We haven't seen a lot of things. So
right. So let's say that this patient has focal fluorescein staining in a vertical line with the keratinization. I absolutely agree that would be the right thing to do. You say, I know what's going to happen. If we don't treat the keratinization, the cornea will get worse. The alternative is the patient just has some diffuse epitheliopathy, but nothing specific to the keratinization. Then I would say the keratinization is not contributing in a major way, and then it becomes a non-intervention.
So
I agree.
You have to decide whether there has been a progression and whether that is being attributed by the lid margin changes or not.
In fact, there has not been any progression in the left eye. It's almost the same. Only thing is the symblepharon has little bit increased. And lid margin keratinization, we are keeping a watch whether it causes any epithelial problem around. Thank you very much for making me wise. Thank you.
Thank you.
This is the question for panel. You said that initially the patient was not progressing here. So during the follow-up period, despite of having inflammatory bouts, that patient has progressed to, as you see on a clinical follow-up. So would the panel agree on immunosuppressing the patient if you had been following him up serially for, say, every 2 months, 3 months, and if you see this picture, a clinical progression, if there is no keratinization of the lid margins?
We are talking of this patient or
this patient?
No, the condition has not worsened. It was only, this is a mild, like acute exacerbation of like conjunctival inflammation or something. His visual status, everything is status quo from the very beginning. Thank you.
Yeah, good morning everyone. And before I start, I would like to thank Vikas, Purvasha and everybody here at LJI for having me here. The presentation about a 13-year-old female child who presented to us on 15th of September last year. And she gave a history of having burning, irritation and foreign body sensation in both eyes since she was 5 years of age. Her mother said that she had an episode of joint pain involving her ankle joints when she was about 4.5, 5 years old. And that resolved with treatment, whatever was done at that time. No reports were available. And subsequently, when she recovered from that episode, she started complaining of photophobia and burning sensation, etc. There was no history of fever with skin rashes, drug reactions, mouth or lip ulcers, etc. And she complained of increasing photophobia, irritation, and loss of vision, more in the right eye than in the left eye since last 1 year. And she had been seen by another cornea colleague at Mumbai about 2 months back, and she was diagnosed as ocular cicatricial pemphigoid. And he had started her on topical cyclosporine and artificial tears. And she was referred to internist. A contact lens trial was also done, but then could not fit the contact lens because of symblepharon, etc. So the internist saw her sometime in August, and these are the blood tests which were done. Everything was normal. ANA was negative. So he started the patient on tablet methotrexate 7.5 milligrams per week, along with tapering dose of oral steroids. So the day she came to us, this is middle of September. These are the clinical presentation. The right eye, as you can see, mucoid discharge, total limbal stem cell deficiency with an epithelial defect, symblepharon, and there are blocked movement orifices. I couldn't really see much of keratinization, but then the lead margin was very abnormal. And the Sharma's test 2 was about 3 millimeter. And this is the left eye. The cornea was clear, but then the lid margin changes were almost similar as the right eye, and there were symblepharon. The Sharma's was also 3 millimeter in this eye as well. So we started her on preservative-free moxifloxacin 4 times a day, along with artificial tears in the right eye, and in the left eye we just gave her preservative-free lubricants. And monitored her for the epithelial defect. This is about 4 days after starting the treatment in the right eye. As you can see, there is an epithelial defect about 4.2 by 2.6 millimeter. We tried fitting a bandage contact lens, but that wouldn't stay because of the symblepharon. And in the meantime, we had got a ESR and a CRP done, which are all normal. But then the patient was already on immunosuppression, so this didn't have much of a meaning though. And the epithelial defect on day 7 appeared a little less, but on day 7, but again when we saw her on day 18, there was a lot of stromal thinning, almost close to 70–80% of stromal thinning. So we planned a multi-layered AMG for this eye. So here you can see the fluorescent stained area showing the area of thinning and defect. So using fibrin glue, we put about 3 layers of patches of amniotic membrane over that area. And the edges of the patch was trimmed. And since we couldn't put a bandage contact lens, we sutured an amniotic membrane on top of the patch to cover the entire cornea using tenonylon interrupted sutures at the limbus. So this is post of day 1, and the area healed nicely, and we continued her on topical preservative-free lubricants. And I spoke to the internist. I was at this point still not sure what the diagnosis was, but since she was already on immunosuppression, so I told him whether, and it was not making any difference, almost 2 months of immunosuppression. So I consulted him, and I requested him if he could hike up the immunosuppression to see if it is making any impact on the state of affairs. So at this point, these are the question: what could be the possible underlying pathology, whether it's a Stevens-Johnson syndrome or a OCP or something completely different? What should be the line of the treatment? Is a conjunctival biopsy justified here? And is her immunosuppression also justified? And what can we do to prevent similar worsening in the left eye?
Quite challenge.
Dr. Chodosh, can you, because I already know about this,
yes.
and I've already
so that is
yeah,
in the
maybe
next
Tim,
slide.
you should give. No, I'm just this. There is no history of any evidence that it's an SJS, either viral fever or
No,
drug
sir,
addiction.
no, nothing.
It's just the subacute.
Joint pain. There was some joint pain. I don't know. But then that also one episode. After that, nothing. Never.
And how old?
14 years
13
old.
now, around 13 and a half, 14.
But the
But
onset
problem
was
started
5
when she was
years.
about 4 and a half, 5.
It's really pushing the limits for me to call it OCP. But
Sorry?
it's really pushing the limits for me at onset at age 4 for me to even think that this might be pemphigoid. You know, I suppose when you have, you know, thousands and thousands of patients with cicatrising conjunctivitis, there's got to be one that breaks the rule. What's the youngest patient, Virender, ever diagnosed with pemphigoid?
I think about 7 or 13-year-old or something.
This would be, you know, so, I mean, pemphigoid is a rare disease,
Very,
remember?
very rare
So now
disease.
you got a rare of a rare. It's so infinitesimally unlikely.
But Dr. Dosh, the question is, I kept her on that immunosuppression till from July till almost December, and I've not seen any change whatsoever, other than the patient feels comfortable once we treated the PED and all that. So would my question is, 6 months of immunosuppression, should that make any change? Will that?
If it is did not make in 6 months, it's unlikely that it's helping in any way. And secondly, is she very photophobic, very light sensitive?
Yes, she is photophobic. So she is not cooperating for the videos. You could see how she was squeezing her eyes. So it's very difficult.
And the lid margin is clean. There is no meibomitis.
Not very clean, Dr. Sangwan. I couldn't appreciate major keratinization, but then blocked orifices. It's not really very normal. But
So-
there's no obvious keratinization, though.
I mean, I think you should take her for an EUA. You need to get a good lid examination. If you're not sure, you
Okay.
need to be sure. And you should be prepared, as we discussed, to do an MMG if the lid is not normal. But because the photophobia could be dramatically improved if, in fact, there is lid margin changes to create that. Does a response to systemic immune suppression help you with the diagnosis? I would say no. Because there are pemphigoid patients that do not respond to immune suppression and end up on IVIG and rituximab. That's why that therapy was created out of necessity, because there are some patients who don't respond to traditional therapy. So I don't know that the response to immunosuppression helps you. And I agree with Virender, if it didn't work, it didn't work. And continuing on, there is always the question, would it have been worse without the immune suppression? That's a valid question. But if you really think it's not working, then it's not working. I don't know what this patient has.
No. At least they are not aware of it. It would have happened many years back, so maybe they don't remember.
Patients give history when you ask in retrospect.
Yeah, I have asked them on 2-3 occasions. I've asked them, but as of now they can't remember. So
I think I think you should pull out all stops in terms of evaluation. So I would have the child seen by a major pediatrician who can think of the rarest of diagnoses. Consider seeing a dermatologist. Do all the evaluation. Is there a component of allergic eye disease? This child is going to be completely blind. So what's the downside, really, to pushing further, looking for rare diagnoses or associated diagnoses that may be atypical presentations? You always have to consider that. Is this an atypical presentation of a rare disease, and therefore we're not able to, with a limited amount of information, make a diagnosis? And these are, the right thing to do, the parents would want to do, is to get a complete evaluation by people who might have insight. It's a wallet biopsy. You know what a wallet biopsy is? That's when it takes money out of your wallet. It's not necessarily a patient biopsy, but to see experts in the field of immunology, dermatology. If this was my child, I would want that, because really you know where this is headed. So I would pull out all the stops and just get a full evaluation. And I think if you're not getting a really good look at the lids, you can do a rapid, fast EUA, and then you'll know.
yeah, and the other thing which really also baffles me is the asymmetry in the presentation of the cornea. The cornea, the left eye, I couldn't show the images, but with fluorescent staining, there was no fluorescent staining on the cornea. The cornea was very clear, though the lids look pretty similar. So I wonder what could have triggered so much of, LSCD in the right eye.
So last OSCON, we saw these horrible cases of families or known people putting acid in teardrops, intentional harm. So that's another thing. Is there something?
Munchausen syndrome, what is Munchausen or something called?
Munchausen.
Well, it can be a Munchausen by proxy, right? Munchausen by proxy. So if someone causing intentional harm, or use of some home remedy that no one is willing to admit.
That is quite possible in India.
Yeah.
Maybe
so
they,
this is very
they don't
interesting.
remember
So the patient that comes in with idiopathic LSCD, progressive disease,
sometimes the patient knows that they did something. Okay, and they don't want to tell you. Now,
Yeah.
that's a diagnosis of exclusion because no one's ever going to admit it. I had a patient with herpes keratitis who poured boiling water into his eye to get the devil out of his eye. Okay, he admitted it, but I could see a situation in which a patient could do something really, really foolish. People do this all the time, and then not want to admit it. Again, but that wouldn't stop me from doing this sort of extensive workup because, you know, if there's something being missed, you can't tolerate missing anything in a child, right? You have to do everything. So that's why I would consider what other specialties might, you know, shed some light on it. And I would be looking for things like allergy and other autoimmune diseases that we haven't considered because maybe they're so rare and we don't see them.
You don't see them.
Yeah.
Yeah, so I was baffled with all this, so I sent the images across to Geeta, and I'd like to acknowledge her help in managing this. After that, we possibly thought that possibly it could be the SJS mucosal variant, and the patient was comfortable, the ocular surface was stable, so we stopped the immunosuppression from January, and we've already done a trial of a mini scleral contact lens for the left eye, and she is comfortable with that, so we'll be dispensing that soon. Thank you.
Thank you, Susmita.